Is my screen running okay?
Yeah, everything looks good.
Great. So today we're going to be speaking about stroke prevention and providing you an update on what's happening in the stroke best practices for prevention. We've just recently updated the prevention guidelines, and so they're hot off the press for you today. We're going to address two specific areas that are new to this year's guidelines to give you firsthand up-close experience on them so you can start thinking about implementation. Before I do that, first of all, I want to introduce everyone to the new look for heart and stroke. As you can see on the slide, heart and stroke has undergone a major transformation, updating our processes and our activities and our luck. The logo you see on the computer screen now, down at the bottom left corner, is our new logo, which was launched this week, and we're very excited and very happy about it. Today's presentation will be in two parts. The first part will be myself talking about a big piece of work we did this year to define what are the core elements of stroke prevention. So if you are providing prevention services, what does that look like? How do you know that you're addressing the best practices and including as many of those elements as possible? The second part will be Dr. Ashkan Shoamanesh, who's presenting a brand new set of guidelines that were added this year on secondary prevention of patients who've had an intracerebral hemorrhage stroke. So this is new. We haven't addressed intracerebral hemorrhage in our prevention recommendations in the past. So just to introduce Dr. Shoamanesh and myself while we're at it, for most of you who know me, I'm the Director of Stroke at the Heart and Stroke Foundation. I'm a nurse by training and have spent much of my career working in the area of stroke and stroke quality of care across Canada. Dr. Shoamanesh is a stroke neurologist. He's currently working through Hampton Health Sciences as a stroke neurologist and as an assistant professor in the Division of Neurology at McMaster University. Dr. Shoamanesh has undergone his training at Boston University School of Medicine. He was involved in the Framingham Heart Study and at the Harvard Medical School. So we're very, very pleased to have him working with us in Canada now and being part of today's presentation. His area of expertise is looking at characterization of hemorrhagic-prone cerebral small vessel disease and the optimization of clinical care for patients who have had hemorrhagic stroke. Between us, the learning objectives for today are to help you understand what the core elements are and how to apply those across Canada, understand some of the strategies that you can use to increase access to prevention, and some of the planning, really neat projects we've been working on this year around geoinformatics, and then to understand what is in those new best practices around hemorrhagic stroke. I do not have any conflict of interest to declare for this presentation. I was a visiting professor in Australia earlier this year, and some of that travel support came from Medtronic. So why is prevention important, and why are we talking about this? Well, let's just better understand what's happening in Canada. So in Canada, someone has a stroke every 9 minutes. We see about 62,000 strokes a year in our emergency departments, and about 48,000 of those actually get admitted to hospital. At least about 10,000 recurrent strokes happen every year. Stroke prevention is critically important to prevent that from happening and to get that number down. We see about 13,000 deaths from stroke each year in Canada, and it costs our healthcare system $3.6 billion. What we know from the research is that for every 100 people who've had a stroke or TIA, 15 will die within the first week. But 20% of those will have a recurrent stroke within the first 90 days. And that is the group that these prevention guidelines are trying to address and try to reduce. Now, when we talk about stroke prevention, we're really focused on secondary prevention, which is an individualized approach to reduce the risk of recurrent stroke. This is for somebody who's already had an event. So what we're trying to do is to look at all of the risk factors, why they had their original stroke, and try to mitigate those as best as possible to reduce the risk for further stroke. In order to develop the core elements, we went through a very extensive process where we completed a literature review, extensive consultation with stroke experts, and with patients about their perceptions on prevention, and then gathered all of those potential descriptors for a prevention clinic and ran it through a process where we did multiple surveys and voting across our expert groups and patients. We then took all of those elements that were defined and used them to create a survey, which is our stroke prevention resource inventory that was conducted earlier this year. Two reasons for the inventory was, one, to validate whether those elements were actually relevant and applicable within a prevention setting, and two, to actually find out where and what kind of services were happening in Canada, because up until now we did not have that information at all. What we found when we did our initial search to identify prevention services is we found 123 services actually being provided across Canada. Many of those we did not know about. And we were very fortunate to get 117 responses to our survey. One of the pieces of this project was really cool. We did what's called geospatial mapping. What you can see on this graph is the location of all those 123 prevention services that we identified. We then used roadmaps and population densities to actually track how much of the Canadian population are within 1 hour, 2 hours, and up to 6 hours of one of those prevention services. When you look at this map, it's the same map looking at drive time, but this time not worrying about provincial borders. We know that many of our clinics currently cannot cross borders, so if a patient is closer to a clinic in another province, they actually can't go there. But part of our system planning is to say, well, how many more patients can we reach if we allow them to cross borders? And so what we found is that we actually had a significant percentage. And these are going back to ministries of health to help them with their system planning. So what's in our core indicators? So we started with identifying what are those kind of principles we wanted to address and where's the big kind of chunks. So what we discovered was the interdisciplinary approach is critical for prevention. It involves assessments. Prevention clinic services involve access to diagnostics, to treatments and interventions. Education is a big part of it, and continuity of care. Now, when we say prevention services, we use that more broadly. It is not, part of it includes all of those services that actually are a clinic with a sign over the door saying they're prevention clinic. But in many of our smaller communities, we don't have specified designated prevention services. But stroke prevention is happening in cardiac rehab programs, in individual offices, and in broader chronic care management services. So we've included all of those in our broad definition. So why do we want to know about these core elements and what do they mean to you? Well, we want to enable you, regardless of size or location, to assess what kind of services are you actually providing. We want you to be able to identify the gaps in the core elements of services that you're providing, which will help you to do planning and development and quality improvement as you move forward. And to understand what elements aren't available currently but might be, and how might you go about addressing those or adding to your list. And really the bottom line is that we want to ensure that all patients who need prevention after having their initial stroke get access to the best and most comprehensive care possible. Our core elements have been put into this model looking at what are the key areas that we've addressed. So in the Centers of Prevention Services, we look at patient-centered healthcare teams. We look at organizational structures, things like technology, scope, referral, diagnostics. We look at processes, which are what are our treatments, risk factor management, and we look at outcomes such as education and evaluation of how patients do. Our core elements within that structure cover the following topics. So as you can see, in each of those big chunks, we have several topics that are addressed. I'm going to show you those in more detail in just a minute. So the first area is designated stroke prevention services. I'm not going to read all these elements, but they're there for you to see and understand. Really, prevention services are, do you have a defined service? How do people get in? Is everybody aware of it? Do you provide just services part of the time, or is it a full-time service? How is it linked to the emergency department? So that's really the designated service piece, is where are you and what is it that you're just, how can you describe yourself? Operation time strictly look at how many days a week are you operating? Is it half days, is it full days, and how many, is it every day or just some days? The staffing, ideally, stroke prevention services will have neurology access, have nursing, have allied health, including physio, occupational therapy, speech, pharmacists, dietitians, social work, case managers as needed, and many other services as needed. But the core is really the physicians, the nurses, and as many allied health roles as are allowed. The service scope really tries to get at, are you providing a one-time assessment service, or are you a follow-up service that will see patients at least a second time to give them test results or ensure that their plan of care is organized, or are you actually in a position to follow them over multiple visits? And what is your relationship to primary care? Do you do this jointly with primary care, working in collaboration, or are you working in the place of primary care in ongoing follow-up? What we know is many of our geographic areas that don't have access to these clinics can start having prevention services provided to their patients using telemedicine. So we do include a technology piece to ensure that everybody's maximizing their ability to have patients access these services. Another big element is referral mechanisms. Do you know where your patients come from? Do all of the areas that refer to your service know about your service, know how to refer, know what the process is there a standard form, and how responsive are you? The next piece is access to diagnostic services, really looking at, can you get a CT, an MRI, prolonged cardiac monitoring or Holter monitoring, echoes when you need them? Are your patients, do you have spots set aside where you can get them within 24 hours or 48 hours, or do you need to do referrals and wait in a long waiting line for those services? Screening and assessment is directly looking at what's recommended in the best practices. Do you use validated screening tools? Do you have a standard set of tools you use on all patients as appropriate to their situation? One example is the post-stroke checklist that we have developed in conjunction with a global group of stroke specialists through the World Stroke Organization. So diagnosis, do you actually have the ability to diagnose what happened with patients and understand the etiology, and to start treatment? Follow-up practices, back to what we said around scope. Are you a one-time clinic, or are you a clinic that actually follows up your patients for a period of time? What is that follow-up? How do you check to see if patients are within therapeutic targets for the medications and whether they're adhering to the prescription? One common thing we hear is, oh, at the prevention clinic, they ordered me a month's worth of blood pressure pills, so I figured that's all I needed, and I stopped taking them after that. Clearly, patients didn't understand that they either needed to go back to clinic or to family physicians to have that prescription renewed and to be monitored on an ongoing basis. So how do you ensure that those patients are, in fact, following their prescribed prevention services and not falling through the cracks? Once patients go back to the community from the prevention service and from our acute stroke services, it's really important that we ensure good communication so the community physicians understand the patient, what's happened, and what you recommend. Further, we want to ensure that these patients don't get lost and dropped out of the system after we let them go from our specialized services. Patient education is really focused around promoting self-management, and it includes both the patient and their family. Heart and Stroke Foundation has many resources such as your stroke journey, the post-stroke checklist, and other educational materials to help you ensure your patients get the information they need when they need it. Each one of you in the region you work in should know what's happening in your community for exercise programs, dietitians, reintegration programs, and ensure that you share that information with your patients. They find it very hard many of the times to find that information on their own, and it often contributes to them feeling lost and unable to reintegrate into society after their stroke. So it's really our responsibility within the scope of prevention services to help them make those linkages. And the final important element of our core elements is quality and accountability. It's great to run prevention services, but how do we know they're making a difference? In Canada right now, we have a real void in terms of understanding what happens in prevention clinics because we don't have a standardized data set. So we really want to encourage all clinics to be collecting data on the patients they see and how well they do. And then eventually we hope to have a standard area to contribute that data. So just, I'm going to finish with sharing with you a couple quick results from the survey so that you can understand what we learned. What we learned is that we have both clinics in rural and urban settings. And in our urban settings, each clinic sees on average 600 new cases a year. In our rural settings, we see about 350. That's one a day. The services are mostly provided in clinics that are ambulatory clinics attached to hospitals. About 20% of our clinics are one-time only assessments. More than half of them actually will have at least 1 or 2 follow-up visits to share results and ensure a plan is in place. And there are a smaller number of clinics that will follow patients on an ongoing basis. Diagnostic services, and as you can see on this slide, we actually divided up the clinics by those who run a few days a week to half of the week and those who run more than 4 days a week. You'll see that on some slides. So one of our questions is, how quick can you access services such as CT, MRI, carotids, Holters, and prolonged monitoring? And you can see on the slide, CTs, many clinics can get them within same day or 24 hours or 48 hours. But the other services take much longer. Screening practices, many clinics will use the Canadian Neurological Scale or the NIHSS. Cognitive screening happens in about 60% of our clinics, and depression screening in about 55. These numbers are low, and we really should see those higher in all of our clinics, so you should really think about what happens in your clinic. Stroke risk with atrial fibrillation is much higher at 83%. We asked our clinics how fast you can get patients in based on need, and these are based on the categories for triage within the stroke best practices. So when you look across the clinics operating on those various times, only about half the clinics can actually get somebody in the same day for a rapid assessment. About half of them can get them in within 24 to 48 hours. Most clinics that we surveyed can get patients in within 2 weeks, and almost all of them can get them in within a month. And that really depends on what their need is, and that has to be assessed. We looked at medication adherence, and most clinics will monitor that if they're following the patient for more than 1 visit. So our call to action for all of you is this. Please follow the Canadian Stroke Best Practices, especially the prevention ones for this content. Now that we've developed the core elements, please look at them and compare your prevention services to these elements and look for opportunities to improve, opportunities to congratulate yourself for all the great work you're already doing, and to ensure that your patients are getting the best access they can. We really want to advocate across the country for improved stroke services, especially in our urban or more rural areas. So I thank you for that, and I will now turn you over to Dr. Ashkan Shoamanesh to share the new recommendations around intracerebral hemorrhage. Thank you.
All right, well, thank you, Patty. Good afternoon, everyone. So next we'll be discussing the second prevention of spontaneous intracerebral hemorrhage best practice recommendations. Sorry, I'm just having some technical difficulties. Okay, perfect. So my relationship with commercial interests are that I do receive a research stipend from Bio Healthcare for my committee involvement with the Navigate EASTIS trial. I have also received Speakers Bureau and consulting fees from Bio Healthcare, as well as consulting fees from BMS Advisor. This program has not received any financial support from any organization. However, the companies that develop non-vitamin K antagonists or anticoagulants, or NOACs, as well as aspirin, may benefit from the sale of a product that will be discussed in this program. So we will center our discussion around a case, and the case will be that of a 77-year-old man who's got a past medical history of coronary artery disease with prior myocardial infarction, dyslipidemia, hypertension, and moderate alcohol intake. His current medications are aspirin 81 milligrams daily, atorvastatin 80 milligrams, ramipril, metoprolol, and hydrochlorothiazide. And he awoke with headache and mild right-sided weakness that gradually progressed to full MCA syndrome with aphasia, right homonymous hemianopia, right-sided hemiplegia, and decreased level of consciousness. And his blood pressure presentation was about 195 over 89 millimeters of mercury. Heart rate was 65 and regular. A non-con head demonstrates a sizable intraparenchymal hemorrhage. The location seems to be within the deep structures with involvement of the putamen as well as external capsule and extension through the thalamus into the intraventricular space. And then you've been asked to see this person roughly a week after his admission. He was on a neurosurgical service, and you've been asked to see him to provide your recommendations for secondary stroke prevention. So just some background is that the incidence of spontaneous intracerebral hemorrhage and the absence of any vascular anomalies or kind of provocative factors is roughly 20 per 100,000 persons in Western populations. And this is a serious disease. It's got a 50% case fatality rate at 1 year, and only roughly a quarter of patients resume independent life. And the cumulative risk of having a second hemorrhage after the initial one is roughly 1 to 7% per year. This differs depending on where the location of the hemorrhage is, in that patients with lobar hemorrhages, who tend to have a higher proportion of underlying cerebral amyloid angiopathy, tend to be at higher risk with a 5 to 10% per year risk of recurrence, whereas those with deep hemorrhages, which are most likely, or most often I should say, due to hypertensive arteriopathy, have roughly a 2 to 3% per annum risk of recurrence. And our first recommendation is that persons at risk for intracerebral hemorrhage, or also known as hemorrhagic stroke, should be assessed for vascular disease risk factors such as blood pressure, and you're really going to be getting your biggest bang for your buck through blood pressure control, as we'll discuss, diet, sodium intake, alcohol intake, and smoking. And as you recall from our case, our gentleman had a history of hypertension and had moderate basically drinking history. So those are his main risk factors that we'll keep in mind. For patients who experience a hemorrhagic stroke, they should also be assessed for risk of recurrence, and the following factors that could be considered an assessment of recurrent risk of hemorrhagic stroke are older age, hypertension, the history of prior lacunar stroke, as patients with lacunar stroke have shared the most common kind of underlying etiology with patients with hemorrhage, that being hypertensive arteriopathy. Lobar location of index ICH, as we discussed, this is suggestive of CAA, which tends to have a higher risk of recurrence. Ongoing anticoagulation with warfarin. The presence of the apolipoprotein E epsilon 2 or epsilon E4 alleles, and these are, again, genetic risk markers for cerebral amyloid angiopathy, and the presence of a number of cerebral microbleeds and cortical superficial sclerosis on MRI. Before we move to the next slide, I just want to mention that, of course, we're not recommending that everyone get genetic studies in patients with ICH, but that these are some factors you could use in your repertoire to try to best predict how the degree of risk that this person is at for a second event. So when looking at the MRI, one thing that you can use that we mentioned was cerebral microbleeds. These are blood-sensitive sequences. This is a gradient echo, but a susceptibly weighted image on MRI can also be useful. And these sequences are sensitive to paramagnetic substances of blood degradation products. So you're able to see occult hemorrhages that have occurred in the past on these sequences that are not apparent on any other imaging modality. And these round hypointense lesions in this top panel are cerebral microhemorrhages. This person has a significant burden of microhemorrhages confined to superficial lobar regions, which is indicative of cerebral amyloid angiopathy, whereas the bottom panel shows cortical superficial siderosis as these linear hemosiderin staining along the sulci, which is believed to be a marker of an occult convexal subarachnoid hemorrhage, which is also emerging as perhaps even a more potent marker of future risk of hemorrhage in patients with cerebral amyloid. So those are basically the things, and in this individual, when we did an MRI, we saw a number of deep microbleeds suggestive of hypertensive arteriopathy. So the first question we have, well, what should be the long-term blood pressure target in this patient? We're not talking about acute hemorrhage, as there's a lot of controversy currently about what is the target blood pressure within the acute setting, but long-term blood pressure management, what kind of evidence do we have to support the guidelines that we'll be discussing in a second? Well, the first is the data from the Oxford Vascular Study. This study is basically an epidemiological study done in Oxford, and in this publication in Lancet Neurology, they looked at patients who had a stroke, either ischemic stroke, which is represented in this purple line here, and that was about 500 individuals, and an additional 100 individuals had hemorrhage, and they're broken down into deep hemorrhages in the red bar and lobar hemorrhages in the green line, I should say. And what they found is what we are seeing here is time frame. As you're approaching the y-axis, you're getting closer to the event that brought him to hospital. So you're getting closer to the stroke, and the bars represent their ambulatory blood pressures up until that point. And in this specific graph, we're looking at systolic blood pressure, and we're seeing that as opposed to ischemic stroke in the purple line, where there's only a slight increase right prior to their event, in patients with hemorrhagic stroke, you're actually getting a marked increase in their ambulatory blood pressures prior to their presentation. And this was relevant for both deep hemorrhages as well as lobar hemorrhages. Similarly, in the Massachusetts General Hospital, which actually runs a very large ICH cohort of roughly 1,000 individuals with ICH, when they looked at the risk of, and I should say the previous graph is looking at incident hemorrhage, so the first hemorrhage. Now we're looking at recurrent hemorrhages. So this is now not epidemiological data, this is hospital-based data, and we're looking at basically patients with lobar hemorrhage on top, non-lobar or deep hemorrhages on the bottom, and their systolic blood pressures on the left and their diastolic blood pressures on the right. And again, and this is just the bars are reflecting their mean blood pressures as an outpatient and risk of recurrent hemorrhage. And what we're seeing is that the risk of recurrence is really starting to differentiate itself once you start getting above a systolic of 130 and diastolic of about 80 to 90 for lobar hemorrhages, and we're seeing similar and maybe even a stronger relationship with deep hemorrhages. The benefits of blood pressure control for preventing stroke were demonstrated in a randomized controlled trial. This was the PROGRESS trial, which randomized patients with stroke, both ischemic and hemorrhagic strokes, mind you, to getting perindopril plus minus indapamide. And the people who were treated with perindopril plus minus indapamide had a mean reduction of their blood pressure of 9/4 millimeters of mercury, and this translated to a 77% risk reduction in probable CAA-related hemorrhages, as well as a 46% risk reduction in hypertensive-related hemorrhages, for a kind of merged data of about a 50% risk reduction with more aggressive blood pressure control. The other indirect data that we have is from the SPS3 trial. SPS3 randomized patients with lacunar stroke to an intensive blood pressure target, basically treatment arm, of systolic of less than 130 versus a kind of a more usual target of a systolic of 130 to 149. And they found that those that were randomized to systolic of less than 130 had a 63% risk reduction in their risk of hemorrhage during follow-up. Again, these are lacunar stroke patients, so this is indirect kind of data that is applied to patients with ICH. But again, remember that patients with lacunar stroke have the same underlying cerebral small vessel disease, being hypertensive arteriopathy, as of most intracerebral hemorrhages. So with this data, we're recommending that patients with intracerebral hemorrhage should have their blood pressure regularly monitored as an outpatient with a frequency sufficient to ensure rapid attainment of target blood pressure levels, and at a long-term blood pressure target consistently lower than 130/80 is recommended. Next, going on to antithrombotic therapy. As you remember, our patient had a history of coronary artery disease and MI and was being treated with aspirin. So what do the current recommendations provide in terms of guidance? Well, in an individual with hemorrhagic stroke, in the absence of other vascular comorbidities is not recommended. So you wouldn't start an antiplatelet agent for the purpose of preventing hemorrhagic strokes, which is, although it seems pretty evident, you'll be surprised at the number of cases I see per year of patients in the community haven't been started for an aspirin after a hemorrhagic stroke and who did not have any other indications. The next is that in patients who were on an antiplatelet therapy at the time of their hemorrhagic stroke, the indication for antiplatelet therapy and ongoing bleeding risk should be assessed before restarting. And of course, that's going to depend on their underlying indication for antithrombotics, as well as the risk of recurrence. And we've kind of discussed about certain things you'll be considering that puts them at higher risk. It may be reasonable to consider using antiplatelet therapy in patients with hemorrhagic stroke and other medical indications for antiplatelet therapy. Treatment should be individualized and based on risk-benefit of weighing recurrent hemorrhage versus risk of thrombotic or thromboembolic events. And the evidence is uncertain regarding timing to restart antiplatelet therapy after a hemorrhagic stroke. So as you recognize, all of these are evidence level C. There isn't any good data to really support these recommendations and is basically based on kind of very weaker levels of evidence and expert opinion. However, there is an ongoing trial in the UK called the Restart UK trial that aims to answer some of these questions. So hopefully we'll have greater levels of evidence for our recommendations in the next iteration. So that addresses antiplatelet therapy for other vascular kind of comorbidities. But what if this patient that we discussed was noticed to have atrial fibrillation during their admission or actually had a history of AF? What are the current best practice recommendations suggesting, and what is the evidence? So fortunately, in the last year, there was 2 large registry-based databases that were published regarding this matter. Prior to this, most guidelines were focused on a Markov decision analysis that was published in 2003 that demonstrated that based on the higher rate of recurrence of lower ICH, that avoiding anticoagulation is likely the best choice, and that if people have very high risk of ischemic stroke or high risk AF, they should be treated with antiplatelet therapy. And in patients with deep hemorrhages who are at a lower risk of having a recurrent hemorrhage, who have adequate blood pressure control, you can consider restarting anticoagulation. Well, the 2 kind of large observational studies kind of provide perhaps a different picture. And the first was a multi-center German registry between 2006 and 2010 across 20 centers. And it looked at 556 patients with AF and ICH who were restarted in anticoagulation. 30% of these individuals had lobar hemorrhage at presentation, and 20% of the overall cohort was restarted. And restarting anticoagulation as compared to being on no antithrombotic therapy whatsoever, or being on an antiplatelet agent, led to a 74% risk reduction in long-term mortality, at 65% risk reduction in new cerebral infarcts, and there was no difference in recurrent ICH rates. I'll go back to this slide just so you have an appreciation of the event rate in patients who were not on or anticoagulants was 11% per year, which is actually higher than what we would expect in kind of your usual AF populations, which suggests that the inherent kind of characteristics and vulnerabilities of patients that leads them to have intracerebral hemorrhages may also contribute to a higher risk of ischemic stroke. This was also replicated in a Danish national prescription registry where amongst 6,000 individuals with AF and ICH, 30% of whom were restarted anticoagulation. Restarting anticoagulation now as opposed to no antithrombotic therapy whatsoever led to a 45% risk reduction in ischemic stroke, systemic embolism, and all-cause mortality, a 41% risk reduction in ischemic stroke, systemic embolism, 45% risk reduction in all-cause mortality. And again, the rate of ischemic stroke in those who were on no antithrombotic therapy here was 13% per year. When you look at patients who were treated with antiplatelet agents, over here compared to no antithrombotic therapy, there was no significant differences in these outcomes. And when you compare patients with oral anticoagulants to those on no antithrombotic therapy, there was no difference in recurrent ICH rates. Now, some may look at this data and ask the obvious question of, are we seeing this reassuring results because there was confounding by indication in that those that were deemed to be at lower risk of hemorrhage were the ones that ended up on anticoagulants, and those that were deemed to be at higher risk were the ones that were not prescribed anticoagulants. And they tried to address this by propensity match scoring, which is a statistical way of trying to account for all possible modifying or kind of influencing covariables. It is an imperfect method that does not kind of supplement the benefits of a randomized controlled trial, but despite these additional analyses in both of these registries, these benefits remained the same and the conclusions did not change. So with this, we have recommended that the decision to initiate or resume anticoagulation following an ICH should be individualized according to the patient's risk of recurrent hemorrhage and thromboembolism. And elsewhere in the guidelines, we do provide kind of recommended scales such as the CHADS-2 VAS score or CHADS-2 score to basically determine that risk of thromboembolism. Patients with atrial fibrillation and previous ICH may be at greater risk of future ischemic stroke than broader atrial fibrillation populations. Initiation or resumption of anticoagulation in patients with non-valvular AF following a hemorrhagic stroke may be safe and reduce long-term risk of ischemic stroke and mortality. Antiplatelet monotherapy can be considered in patients with AF who have suffered an ICH and deemed too high risk for anticoagulation, and aspirin could be considered as the first-line antiplatelet agent. This is based on basically prior randomized controlled trial evidence showing that aspirin results in roughly a 20% risk reduction in thromboembolism in patients with AF. Mind you, those trials excluded people with ICH. This is why it's evidence level B. And whether the reported efficacy and safety profiles of non-vitamin K oral anticoagulants persist in patients with previous ICH is uncertain. Given the years of the registries from Germany and Denmark that I showed you, NOACs only accounted for about 3% of anticoagulants used. So the majority were being treated with warfarin, and there currently is no evidence, or no data at least, that has been published that I'm aware of where they actually show the risk benefit of DOACs within AF patients who have suffered an ICH. They were excluded from all randomized controlled trials looking at the question. We are, however, starting a pilot study across Canada that will hopefully answer this question in the next few years. And anticoagulation with warfarin is best avoided where possible in patients with cerebral amyloid angiopathy. There's now a lot of observational data that shows that patients with CAA who the continuing warfarin is one of the major risks for having a recurrent bleed. And these patients would be best managed through consultation with an expert in cerebrovascular disease. I have suggested that the wording is best avoided where possible because, of course, there are situations like mechanical mitral valves where NOACs are not an option. Antiplatelet therapy is really not the best option, and you may have to bite the bullet and continue warfarin. But again, the decision needs to be made with an expert who has had training in cerebrovascular disease management. And the optimal timing of oral antithrombotic therapy following a hemorrhagic stroke is uncertain and should be individualized to the patient. Waiting a minimum of 2 weeks prior to oral anticoagulant therapy following spontaneous ICH is recommended. And usually what I would do is repeat a scan at that time, make sure that the hemorrhage has been stable and that it is no longer progressed prior to initiating antithrombotic therapy. And in this case, if that we discussed at the beginning, what I would have put kind of in my risk-benefit analysis would have been that, well, this person was older than 75, he was hypertensive, his CHADS-2 score was a 2, that would put him at roughly a 4% risk of ischemic stroke per annum. He had a deep hemorrhage that has roughly a 2 to 3% risk of recurrence. I could reduce that risk by 50% if I manage his blood pressure aggressively to a systolic target of less than 130/80. So overall, I think the benefit of, I would start that person on an anticoagulant given the 70% risk reduction in ischemic stroke that we see with anticoagulants in patients with AF. And although there's no data to guide it directly and we can't put it into the recommendations, I am beginning to use NOACs in this population, but of course that's outside of the recommendations as well as maybe not be the most common practice across the board. Next, just to discuss the timing of antithrombotic therapy, where does the 2 weeks come from? The 2 weeks comes from previous guidelines across the board, whether it was the AHA or so, that recommended 2 weeks based on expert opinion, and that expert opinion kind of stems on the expected evolution and clot maturity that we know in animal models of hemorrhage. But there has been a recent study that has changed other guidelines. So some may notice that in the past year, the American Heart Association as well as the European Stroke Organization have changed their time to wait prior to restarting anticoagulation. For the ESO is 2 to 30 weeks. For the AHA, they're now saying at least 4 weeks. And in the European Heart Rhythm Association is saying 4 to 8 weeks. And what has really influenced those guidelines is a study by Sam Schulman here at McMaster and his colleagues that looked at kind of when was the most optimal time of resuming antithrombotic therapy after, or warfarin I should say, rather than antithrombotic therapy, and that should be after any type of intracranial hemorrhage for various indications. And their conclusion was that the sweet spot seems to be somewhere between 10 to 30 weeks, and in the conclusions, however, they say at least 4 to 8 weeks waiting. At least 4 to 8 weeks is recommended. The reason that we have not let this data, although I think it is a heroic effort at creating some data in an area where there currently is none, the reason we haven't allowed this to affect our guidelines is that we don't believe that it entirely applies to patients with intracerebral hemorrhage or intraparenchymal hemorrhages, nor, for instance, in the context of AF, and in particular because the indications were quite different for why these people were getting anticoagulated with warfarin. So 50% was roughly AF, 50% was roughly mechanical valves, roughly 20% were venous thromboembolism. There was some overlap between these indications. And although that the baseline ICH was almost a split 50-50 between intraparenchymal hemorrhages and subdural hemorrhages were markedly overrepresented in recurrence rates. So 2/3 of recurrence rates were subdurals, despite only roughly 43% of those at baseline having a subdural. So we believe that this data reflects or is much more strongly relevant to subdural hemorrhages, and unfortunately they didn't have the numbers to really tease out the differences between intraparenchymal hemorrhages and subdurals. So we don't know whether this data really applies to IPH, and that's why we haven't factored it into our guidelines. And lastly, this patient was on a lipid-lowering agent, a Lipitor 80 or atorvastatin 80, because of his prior history of coronary heart disease and MI. And one controversy that's still out there is what to do with lipid-lowering agents in patients who have suffered a hemorrhagic stroke, because the only randomized controlled trial that looks specifically at secondary stroke prevention and the benefits of statins was SPARKLE, and within SPARKLE, patients who were randomized to atorvastatin had roughly a 70% increase in their risk of hemorrhagic stroke during follow-up. And this had raised alarm bells about, I should say, for patients with ischemic stroke and TIA, this was offset by the benefits for ischemic stroke prevention, but it has raised the question about what about patients who have a hemorrhagic stroke on top of their prior indication, whether these agents should be continued. This was a matter of controversy for several years, and it still is, but some reassurances have been brought out by a meta-analysis that kind of put together 31 randomized controlled trials that looked at this at statin in a randomized fashion, and they found that there was no statistically significant increased risk of future hemorrhagic stroke in either primary prevention or secondary prevention studies with the use of statins. So this has led us to say that, one, of course, statins should not be initiated for secondary prevention of ICH, and that in individuals with other clear comorbid indications for statin therapy, there is insufficient evidence to withhold statins. And this is, again, another trial that's starting perhaps in the U.S. in the coming years to look at this question. Of course, with the current level of evidence, these are evidence level C's recommendations. I will just mention that for our case, of course, given the person had a prior myocardial infarction, and we're talking about secondary prevention of an ischemic event where the benefits of statins are rather robust, in such a case, I would continue statin therapy. And that is, I believe, the end. So thank you for your attention.
Great. Thank you very much for that great presentation. If anyone has any questions, if they can just send them through the chat function. We do have a couple just to start us off. One individual is wondering, with patients with history of cerebellar stroke undergoing rehab, and the resting blood pressure is at 152/80, would you advise that they go forward with intense rehab or not?
Yes, there's really no data to suggest that small spikes in blood pressure in the context of exertion, either physical activity or sexual activity or anything of that nature, renders a greater risk for that short period of time. It's mostly kind of more long-term ambulatory levels of high blood pressure that kind of contributes to the risk. So if someone was in the 150s, that would not concern me. If they were maybe greater than 190, I would have some concerns, but there would be no data to support those concerns. But I would preferably wait until the blood pressure is lower.
Great, thank you. And then we have one other question. Looks like someone has had a few cases around sneezing and coughing and hemorrhaging. And they're just wondering if there's a posture or maneuver that they can do with those that have reoccurring lesion to reduce further hemorrhaging.
So coughing and sneezing or Valsalva maneuvers and stroke mechanisms, where there is evidence is that sometimes there have been loose associations with these maneuvers and having arterial dissections, as well as contributing to paradoxical embolism because the increased intrathoracic pressure can aggravate right to left shunts. As far as whether, again, a brief spike in the blood pressure will contribute to hemorrhage, I'm unaware of any data, either observational or anything else that suggests that there's been an association with these maneuvers and having an ICH. So I wouldn't worry about them.
Okay, and is the blood pressure target post-ICH related to office BP? What would be the ambulatory or home BP target?
That's a good question. All the data we have thus far is from office BPs. So, so I should have mentioned, yes, sorry, that was outpatient office BPs in the studies that I commented. Whether that should be modified for home measurements, really what I try to do is try to get their home measurements and get an idea of how their home measurements with their particular machine, because there's so much variability based on the machines and models that they use, how their home readings kind of apply to mine, and sometimes I'll even ask them to bring their machine to the office, and then I'd be able to make my own adjustment based on the individual.
Okay, and can you comment on blood pressure controls for older adults and secondary prevention, older meaning over 80?
So I know at least there's been some concern about blood pressure control in elderly and contribution to falls and syncope and so forth. I should say that in the SPRINT database, of course, although there was issues with renal dysfunction and hyponatremia, there was no significant increase in falls. And in SPSRI, which was an older population with lacunar stroke, there was no significant differences with targeting less than 130. So that doesn't really factor into my analysis. Really, if someone has had a hemorrhagic stroke, my biggest concern is preventing another one, and the biggest bang for your buck you're going to get right now. Really, the only kind of evidence we have that we could actually mitigate the risk of future events in these patients is blood pressure control, and that's going to be my priority.
Okay, great. And those are all the questions that we have for today. So thank you, everyone. Oh, let's see. One more question came in. When will the updated prevention guidelines be released?
I'll defer that to Patty. I know my section still has to undergo another kind of skim through and external review, but I'll defer to Patty.
So the prevention guidelines are currently under external review, so you've all gotten a sneak peek today. We will be hopefully sending those in for publication first thing in the new year and expect by early February to have them in the public domain. That being said, the core elements that I spoke about earlier in this presentation will be available on the Stroke Best Practice website by early December. And you can reach them at strokebestpractices.ca.
Okay, so that's it. Thank you very much to our presenters today for joining us, and as well to all of our attendees. Please make sure to complete the evaluation, and we will also, as mentioned, send out the recording along with the additional upcoming events that are happening with Stroke Best Practices and the Heart and Stroke Foundation. So thank you again, and have a great day.
Thanks, everyone. Bye-bye.
Thank you.